The way we do select or apply, we just read the question and we come up with our ask, which is the last portion of the question. And then the case, which is the rest of the question. And then you look for the buzzwords, that means keywords in the question. And then you rewrite it with your content and you take those information and you use it to analyze each question, answer choice that you've been given. You don't compare anything and you pick your answer and you move on. So based on what we have, we will figure out our asked. And this is by just reading the last portion of the question, like I said, it's a select all that apply. Which of the following the next should expect an assessment? So every question, there is a theme the examiner want to portray. So when you read it, try to get into the examiner's mind. I'm trying to figure out why they wrote this question and what they want you to learn from each question. We're looking for what? Which of the following the next should expect an assessment? So that's our ask, which is an assessment. So the answer choice assessment. Then you read the rest of the question. Like I said, you're reading from the backward. An unrestrained passenger client was brought in to the trauma bay after a head-on motor vehicle and collision. Requested a strict spine precaution. Which of the following the next should expect on assessment? So this is the full question that we have. We have a question asking us to do what? Do assessment, and if given yes, the rest of the case. So you have to now go back and look for buzzwords. Buzzwords are key things the examiner wants you to know, but they don't want to give it to you. They put it in the question form for you to go look for it. So we're looking for an assessment, and then an unrestrained. The passenger is unrestrained is a buzzword. Was brought into the trauma bay after a motor vehicle collision. All this is saying is the patient was involved in an accident. That's all. The physician requested what? A strict spine motion restriction. Which of the following assessment the next should expect? So what they're trying to ask you is, what do you think if I'm requesting a strict spine precaution? You should anticipate certain things I have seen by examining the patient. That is why I'm putting in the order. When a physician make order for blood pressure medication, there is a reason why they do that. They read because the patient blood pressure may be too high. The same thing. If I'm ordering a strict spine precaution, then there's something that is not right with the patient. When you rewrite this 6-line question, you said patient has injury, so motor vehicle collision. So that's my rewrite. So, okay. I don't know what she had, the patient have, but there's what? Spine precaution. I need to do spine precaution. That's all. These two words basically analyze the whole thing. In the trauma bay, when the patient come in, when we see trauma, we go through our head. There's a criteria you have to use, and then we call it NSAID. So N, the patient has to have a neurological complaint. So they should have a neuro complaint, or your exams is abnormal. That's the first one. Then the S, they should have what? They usually greater than 65, so 65 years old. They may not give you age, and NCLEX doesn't give you age, but they will give you age. It's very, very important. So 65 years old, or there is a significant, these are the two things, significant trauma. Okay. And then the A, as you spell, the patient has to be altered. Then the I, intoxicated, or they are on any drugs. Then the D, basically, you have to have distracting injury. Then the S is you have a spine tenderness or spine injury, basically. If the tenderness, you assume that there is an injury there, no matter what. So this is what you use to answer any spine question. If you have to initiate spine precaution, all this thing has to be satisfied. If the patient have the symptoms, then you should institute that. So neurological complaint, that means you do exams and then it shows that there's evidence of neurodeficit or the exams is abnormal. Patient is over 65 years. If they don't give you the age, look for significant trauma, like a lot of trauma involved. The patient is altered, they have lost consciousness or they don't remember amnesia. They don't remember the event. They're on drugs or alcohol, whatever it is. They intoxicated on something. And then they have distracted injury. Distracting injury is an injury that is patient can see and they're worried about it. It's distracting them from the worst injury they've had. They may have spine injury, but they have fracture in their leg and they have pain in the fracture. So they're focusing on the pain in the fracture and they don't want to think about the spine injury because they don't know. They're being distracted and you cannot examine them completely to find if they have a spine injury because they are distracted. And then when you do exams, any spine tenderness is assumed that there is an injury. And so this is NSAID. So that's why you take NSAID for spine injury. I'm joking, but that is the way I remember them, is you take NSAID for back pain, open tibia fracture. Yes. If I'm going to examine your back to look for injury and you have open tibia fracture, this is a distracting injury. A client is 70 years old. Yes, more than 65. Thoracic spine tenderness. Yes, there is a direct spine tenderness. Therefore, we'll take that. Blood alcohol level abnormal. Yeah, patient may be intoxicated. Client does not remember the event, so they are amnestic to the event. So this is bad. No tone on digital rectal exams. This one required a level of critical thinking. Your sphincter tone is controlled neurologically. So if we do a neurological exams, the easy way to know somebody has a spine injury is to check their rectal tone. If it's completely flaccid, there's nothing, no tone at all, then maybe spinal shock or there's a spine injury. So this requires you taking back what you know from your class, from your fundamental physical exams, that if I don't feel a rectal tone, there is something wrong with the spine, and therefore this is good. So that's a injury, basically neurological exams is abnormal. So digital rectal exams is a portion of your neurological exams because it tell you there's something not right. A right arm pain. Pain is not a neurological problem. It does not satisfy the age. It doesn't show alteration, no intoxication, no distracting injury, just pain in your arm. It's not completely distracting because we don't see any injury. I don't see that there's a what did they call it? I did not indicate that there's a fracture there or there's something, just they have pain in their hand. Of course, they involve in the motor vehicle collision. So simple pain in your hand should not be something that can distract you. Okay. They tell you they have pain, yeah, I'm fine. But if they have a true fracture, yeah, there's an amputation. Yeah, I will worry about that. I just put it there because it can be distracting. Somebody will select that and say, oh, okay, that may be me personally, I will not choose that. Just having pain in your hand without any fracture there, without anything there, without no obvious. The answer choice doesn't tell you there's an open wound there or anything like that. I expect the patient to have some pain, but open tibia fracture is really true distracting. So those are our answers for spine precaution. You got to take your NSAIDs. Okay. So that's that one. Similar thinking, similar strategy, how to answer questions. The same thing is a SATA question. Which of the following statement by the caring nurse will require immediate intervention by the nurse manager. So you have a client with anorexia and malnutrition was placed on what? NG tube intermittent feeding. She was due for a 8 a.m. feeding. Which of the following statement by the caring nurse will require immediate intervention by the nurse manager? So our ask is the nurse taking care of the patient made a mistake, would have said something that will cause the nurse manager to intervene. What is the issue? We have a client that is anorexic. Those are your buzzwords. Is getting malnutrition placed on what? Second buzzword, NG2 feeding. So you have to look for the main thing for the buzzwords. Don't look at it. Not every word is a buzzword. She was due for 8 a.m. feeding. It's fine. Which of the following statements from the caring nurse will require immediate intervention? So anorexia, NG2 feeding, right? And then we have to feed the patient for 8 a.m. So I'm going to give the patient feeding. Patient is anorexic and is getting intermittent feeding. So we have 8 a.m. We have NG2 feeding, which is intermittent, okay? And then we have anorexia patient. That's all. I'm feeding anorexic patient who's getting intermittent feeding. Which one would the nurse manager intervene? So there's few content stuff you got to, whenever they give you NG2 feeding, they try to trick you. So I will give it to you shortly. So there's two types of feeding, okay? Feeding tube, okay? You can have intermittent or continuous. Whenever they give you intermittent NG2 feed, there's certain things you have to know. You check residues, okay? Before feeding and after. So sometimes the after doesn't matter, but before feeding is the most important. You don't check every 4 hours. No, negative. That's where they get you. For continuous feeding, this is where you check every 4 hours because you're getting, think about it. Start thinking about things. They're giving you, I'm feeding you continuously, where then I shouldn't you check your residue continuously, right? If I have a tube that is going on feeding you continuously, as you check how much food is left in your stomach every certain hours. So this one, you check it every 4 hours to see how much is left, whether the patient is emptying, that means the food is leaving the stomach and going downstream. So that's why you got to check it every 4 hours, okay? You don't do intermittent checking on that. You have to have a schedule and check it. The second thing is, what do you do when you get a residue, okay? The residue, there's so many norms. So first thing I would say is institutional base. So whatever your institutional policy is, what to deal with residues, then you can deal with that. So if they ask you a question, if the answer choice say institutional base, I will pick that, okay? Secondly, there's certain norms, okay? You never, before that, don't ever throw residue away. Don't ever throw it away. No matter how large it is, if the patient, not like 2 liters, no, there will be no residue, 2 liters, but if a certain amount, sizable amount, still give it to the patient. Because it's part of the fluid, that's the nutrition to prevent dehydration, okay? So residue, what you do with it is institutional base, and don't ever throw it away and give it to the patient. Let me make it easy for you. Let me make it easy. So when you come up with your mind and said, hey, institutional base, I don't have to throw it away. Then when you check the residue, the amount, you have to know what to do with it. Okay, every amount that you get, see if the patient is tolerating it. If tolerating it, how do you know? So no nausea, no vomit, no abdominal distension, okay, and no diarrhea. So if I don't see all these things, I know that patient is tolerating the feed. Therefore, I'll continue the feed. Okay, and give the residue back. If it's greater than 250, that's where you got to be careful. And then you have to 100% check if the patient is tolerating the feed well. 250 for sure. You got to. Sometimes some people get less than 250, they don't check whether they tolerate, they just give it to it because it's acceptable for certain institution. So if it's greater than 250, you definitely have to check and make sure they tolerate it. They don't have diarrhea, they don't have distension, no vomit, and they're doing fine. And then you can give it back to them and you continue. If they are not tolerating it, yes, you still give it back to them and you hold the nutrition. Once again, if they are not tolerating feeds and you get even 250, give it back to them and don't give them the nutrition anymore. Just hold it for some time. But you got to retain the fluid you took. You're taking fluid from them. You have to give it back to them. So that's very, very important. So 250, some people say go up to all the way 500. No, I mean, I think 250 is the is the solid foundation. Like if it's less than 250, I give it to them. I may not check whether they tolerate it, but if the question asks you, if it's high, check and see if they tolerating it. No nausea, vomiting, no abdominal distension or diarrhea, then give it back to them. If they are not tolerating, even if you get 80, if the volume is low and they still not tolerating it, yeah, you hold the feeding, but give them their residue back. Okay, so that's what we're going to use to answer the question. And so just pay attention with that because they can trick you. The other thing too is, so check residue every 4 hours. It's an intermittent feed. The key word is what? Intermittent. It's not continuous feed. Okay, intermittent feed. You check residue before you feed the patient. You don't need to check it every 4 hours. So this is wrong. So this is where we go to intervene. Discard residue if greater than 100. It's partial. There's no information there. You don't discard it. You got to check and see if the patient is tolerating the feed or not. Or it's based on institution. If they said based on institutional, yeah. But so this one we got to intervene. Start 8 a.m. feeding right away. No, you got to check placement. X-ray or gastric pH from your residue. This is the reason why you check residue before you start feeding intermittent, because the tube may displace. So you check the residue and you check the pH, and if it's acidic, you know the tube is in the right place before you start feed. That's why you check residue for intermittent feed. So start this thing, we got to intervene. Abdominal X-ray now, good. We're confirming position, so we don't need to intervene. Check gastric pH from residue. Perfect. Remove the stylet from the NG tube before feeding. There's no stylet in the NG tube. The one that stylet is the NJ, nasojejunal feed. These are feed that go all the way past the stomach and go into the jejunum or nasojejunal tube, ND tube. So those ones, yeah, as a stylet, and the stylet basically guide it to where it's supposed to go. And then you get an X-ray first, and you look at the wire. If the wire tip is in the right place, you pull the wire, and then you start feed. You don't pull the wire until you have confirmation. If you pull the wire out, and then it's in the wrong place, you got to replace the whole tube. But NG tube doesn't have started. It's just a plastic. The NJ, they are very small and they can be used for feeding that go into the jejunum, and they have a started. So I just put it there so that sometimes they confuse you. It's not the same as NG tube. And so this one we need to intervene. And so those are the things you need to intervene about the question, about this specific issue. But I put these two questions there to help you think, see how you can analyze critical thinking, and then breaking down the question, break it down into pieces so that you can figure out like what exactly the examiner want to portray. Okay. Thank you for staying around, and all the best of luck, and keep charging as always. And please subscribe if you have not. The link is right down. Click on it, put some comments to help grow the channel. I would like to read your comments. Thank you very much. Bye-bye.